So a very good morning. My topic for this session is lower eyelid blepharoplasty, the effects on the functional epiphora. I can I switch on the slides? Okay, thank you. So I know financial disclosures. As we all know, the lower lid has a major role in the maintaining the blink mechanism and the lacrimal pump mechanism. So any surgery which is involving the lower lid, either it could be a blepharoplasty, lower lid blepharoplasty, we need to maintain the tightening and the laxity of the lid in a very adequate way to get the good functional outcomes. So lower eyelid blepharoplasty, it is being a time tested technique, which usually considered as an aesthetic surgery. It causes a positive changes in the restoration of the aging periorbital tissue concerning the brow and the cheek for a youthful facial look. So while fat and skin excision are still carried out with the current lower lid blepharoplasty, present trend follows a tissue preserving philosophy that may include the orbital and the soup relocation and the fat transposition to restore the apparent volume loss associated with the facial aging. So lower eyelid blepharoplasty, we have the documentation where strengthening procedures when combined like in the form of a saptorrhaphy or tightening of the orbicularis muscle or a lateral canthal tendon in skin yields the favorable functional outcomes. So now when we talk about the SMES, that is the superficial musculoaponeurotic system, which is often described as an organized fibrous network, which act as an aponeurotic mask and invest the facial muscle and connect with the dermis. It is uniquely positioned to reflect and respond to the global eye movements. So the concept of SMES is generally accepted in the aesthetic surgeries and is applied to correct the ptosis of the facial fat in areas prone to aging, whereby the SMES is drawn up and fixed to the more superficial muscular and the dermal structures. So the functional epiphora is kind of a subjective symptom of overflow tears, is a major determinant of quality of life. So by keeping all these points into the consideration, we have considered that when we perform a lower lid blepharoplasty with the SMAS and the orbicularis oculi lift, it can alter the horizontal lid vectors with an improved eyelid contour and eyelid tension. Definitely decreases the excessive skin fold and has the lid laxity, and it causes strengthening of the lateral canthal tendon. So it can result in a refined blink mechanism. So with all this, we have formulated a study where we try to assess the effect of the lower lid blepharoplasty with an SMAS and the orbicularis oculi lift on the improvement in functional epiphora and the quality of life parameters. So this study was conducted over a period of 1 year. It was a prospective international study where 18 patients approved by the Research and Ethical Committee underwent the lower lid blepharoplasty in SMAS and orbicularis oculi lift. So at pre-operative and a post-operative assessment was performed at 1 month and 6 months. For the epiphora grading, we have considered the monk score, the traditional one, and the for quality of life questionnaire, we have considered the validated lacrimal symptom questionnaire. So the authors preferred surgical technique was a transconjunctival approach. However, we also given a transcutaneous incision for the SMAS orbicularis oculi lift. So medial, central, lateral fat pads are fashioned into the 3 fat pedicles, which are repositioned or relocated beyond the infraorbital rim into the SOF area. In order to strengthen the lax orbicularis oculi, the SMAS orbicularis complex is identified and a flap is fashioned, which is then lifted and fixed to the inferomedial superficial temporoparietal fascia. So the results were obtained after a 6 months follow-up visit, where majority of the patients in terms of the anatomical results have achieved a symmetrical and the adequate lid contour. A high lid slant was observed, however, in the 2 of the eyelids. In terms of the functional results, we observed a significant decrease in the monk score in comparison to baseline, both at 1 month and 6 months respectively, and a significant improvement in the quality of life parameters at 6 months follow-up visit. So coming on to the discussion, previously the upper lid blepharoplasty have been evaluated and documented, resulted in comparison to the functional epiphora. However, the literature is still lacking and no study have yet performed which have considered and compared the lower lid blepharoplasty in relation to the functional epiphora. So basically this is a surgical technique, so I would like to highlight few of the surgical points which we need to take care to get the good functional outcomes. So why we are given with the both 2 incision, that is a transcutaneous and transconjunctival. Transconjunctival definitely because it provides a better access and repositioning of the fat pads. Plication of the SOF and suspension of the midfacial tissue are effective in midfacial rejuvenation, and same aspect we utilize in our current technique. However, the SOF as being an elusive entity and can only be visualized from the suborbicularis space during a skin muscle flap procedure, and that's why we given a skin incision. The second point is that we need to take care of the critical zone, which contains the terminal tweaks of the zygomatic branches of the facial nerve that supply the pretarsal and the preseptal orbicularis oculi muscle. If we are going to damage this, then this may result in the iatrogenic ectropion or weakness of the lower eyelid following a transconjunctival lower blepharoplasty when we combined with the smash. The next point is the Clifford ligament. As you all know, it's an arcuate expansion of the Lockwood ligament and it inserts into the inferolateral orbital ring. So this ligament has a major role in maintaining the lateral support, and that's why we need it served to check the inferrectus and inferoblique muscle, and it's a protective mechanism to prevent the excessive backward displacement of the Lockwood ligament. The fourth point we have kept into consideration, that is the inferior oblique. The inferior oblique usually remains spared very well in the transconjunctival approach. However, when we perform a smash orbicularis lift, then aggressive transposition with simultaneous stretch can cause IOM and has result in diplopia. So being the small sample size and heterogeneity in terms of excision and repositioning of fat set, these were the limitations of the study. And here I would like to conclude. The lower light blepharoplasty led to alteration in the orbitomolar vectors along with improved eyelid contour and eyelid tension, reduction of the excessive skin fold with lid laxity and strengthening of the lateral canthal ligament, hence result in a refined lacrimal pump mechanism. It acts as a promising technique to reduce the bothersome functional EP4 and improve quality of life. Thank you. Yes, sir. So basically, we have any case even with a medial ectropion was rolled out. We have just considered all the cases where we just got a skin laxity in the form of either a medial canthal laxity or horizontal canthal laxity, but without any component of ectropion. If the puncta was opposed, then that is the initiation of the ectropion. Sir, we have performed the basic test for the ectropion. We have done all the laxity test. We have performed the lateral medial canthal. We have done the pinch test also, sir. But I don't think in any of the cases there was a component of ectropion we have considered the patient for the study inclusions. Except this, we have not performed any tests, sir. Yes, sir. Right, sir. Right. Right, sir. Right, sir. So right now, so we are just went ahead with the observation at 1 month and 6 months. In future, we can consider this component because definitely the Botox is one of the main utility which we use in advance. Right, sir. But in Botox, sir, definitely the patient will require the frequent 3 to 6 months again and again, and the cost effective is a. Okay, sir. Right, sir.
So nice presentation, Dr. Deepak. Thank you.